chest injuries, and only chest injuries. We need to make sure that you understand the fundamental anatomy of the thoracic cavity and the things in it. Is that mango? Sure. I went on a date once. I took a chick in the middle of Flint. We had this secret, right in the middle of the ghetto, a little nature trail. So I bought me a mango because I'd never had a mango. Took it on a date, which is, young Steve didn't really know how to, anyway. We're out on the thing. I bit into the mango and I was like, wow, this tastes like a bitter carrot. Like this is, and I was like, ugh. So I just pitched it into the pond there and a snapping turtle grabbed it. And then he floated up to the top after he bit into it and was like, phew, and spit it out like a cannonball. And I said, that's what I just did. Like, I bonded. It was nature. Anyways, thoracic cavity. Obviously, we're talking from neck to diaphragm, and regarding the trachea, the lungs, mediastinum, and pleural cavities. We need to be aware of all of that stuff. As a reminder, mediastinum is this area, let's say, in the center. I don't know that I'm ready to say cavity. An area in the center encompassing all kinds of things. What is in the mediastinum? Heart, good job. What else? Huh? Vena cava, a lot of the great vessels, right? Even the esophagus. You can see here as at the number 3 where the heart is, that's where the mediastinum is. And that's going to become important because as we develop pneumothoraxes and hemothoraxes, it will compress inside our thoraxes and it will compress against that mediastinum. It's a problem, of course, because not only putting extra workload and pressure on the heart is bad, but so too is collapsing those great vessels, and eventually it will shift your trachea. It also includes phrenic and vagus nerves, but that's kind of a holdover. I don't expect you to know too much about the vagus nerve right now, except, what do we know about the phrenic nerve? C3 through C5, C3PO, keeps the phrenic nerve alive, which is your diaphragm, right? Very good. What's the vagus nerves? It is parasympathetic. If I squeeze your adrenal glands, what kind of juice comes out? Sympathetic juice, right? Epi. If I squeeze your adrenal glands, epi comes out, makes your heart rate go up, right? Well, you got vagus nerves. If I squeeze those, the juice comes out, makes your heart rate go down, right? You ever heard of vasovagal syncope? Vasovagal syncope. Basically, this is what happens when, I'll be 67 years old, drop my drawers, go in to take my morning constitution. YouTube can't see the motion right now. We'll just have to explain it. In any event, they'll bear down putting pressure because your vagus nerve will run all the way down through your abdomen. And when you bear down on that, it will cause your parasympathetic hormone to be released and drive your heart rate down. And if you're 67 years old, or the farther you get towards the grave, essentially, the less you're able to recover from that parasympathetic hormone, and it might make you pass out. And so you are at the beginning of a career that will do one of 2 things more than most. Number 1, dialysis transports. And number 2, geriatric patients passing out in the bathroom, the garages, and the kitchen. Those things more than most. Part of that is they're just putting pressure on their vagus nerve and bearing down. In fact, it's one of the things we do as paramedics. If I check a heart rate and it is too high, one of the first things I say is, hey, remember when you pooped before? Pretend like you're doing that. Bear down really hard. It'll put pressure on a nerve that will slow your heart rate maybe. Make sure you understand the ventilatory innervation, like we said, C3 through C5. But also, they're not the only ones that innervate our respiratory system. There's the intercostal as well. That's in our thoracic cavity. If you remember, right, that's where our shelf is on the back. If I run my hand down the back of my neck, or Brandon's, Essentially, that's our C7. And so above that is where we're having major concerns for diaphragmatic injuries. If I've got traumatic spine questions, the first place I'm looking is there. When we start to put together a detailed physical assessment, do you see why it's worth points to separate and immediately identify as you investigate a patient's neck to not just look for midline trachea, the neck veins, but also step off of the what? Cervical spine. Why do I care that you check that almost immediately? Because it'll affect their breathing if it's broken, right? That's why it's so important that we're in there. We're just kind of take a quick sweep of that. It might let me know that a storm is coming in a big way. Like that, environmental humor, boom. Pathological afterload. Somebody tell me what preload is. Blood that's going to the heart before contraction. Anything else? Say it again. It is before contraction. Yep. How much blood is in the ventricle before contraction? We're getting even closer. Absolutely. Anything? This might be an A&P guy kind of question. Anyways, what we'll talk about in cardiology is what's called Starling's law. Starling's law. Essentially, the idea is if I've got a basketball and it's got no air in it, how high does it bounce? Not high at all, not unless I throw it, right? If I put enough air, if I put 100% air in it, then it will bounce. But if I overfill it to like 110, like they do in basketballs, that thing will bounce to the moon, right? Kind of a sports guy. Just throw a quick sports metaphor there. Anyways, like I was saying with basketball, when the goalie isn't blocking it, no. The point is that preload we talked about before is, yes, blood filling the heart before contraction. Now I need you to know that it is blood overfilling the heart. Overfilling the heart. It's the reason why I don't need a chest-sized heart. I can just use a fist-sized heart because we overfill it, and based on Starling's law, that allows us to pump all the way to our tippy toes with such a small muscle, overfilling it. So preload isn't just the amount that the blood returns to the ventricles, but it's basically the amount those ventricles are getting stretched by the blood. Now, afterload is on the other side, right? But it's not exactly the opposite of preload. Afterload is the pressure your heart has to push against, right? If my blood pressure is 120/80, how much pressure does my heartbeat have to overcome to pump blood out of the heart? 80, because 80 is my resting or my diastolic, right? That's what's in my vessels without contraction. Stenosis means to harden. And so a stenosed valve means that it's hardened and it's not opening very well. The heart has to pump harder against that valve to open it if you have stenosis. So increased stenosis of the aorta, increased afterload, it overworks the heart. When we're working out, we are breathing, we are working out at a normal scale, like a quick jog around the neighborhood. We are not overworking our heart. When we make our heart work against a pathological situation, it causes our heart to atrophy or hypertrophy specifically. All I mean to say is if we overwork our heart unnecessarily, we shorten its timeline. So if I've got systemic hypertension or pulmonary hypertension, if I live with high blood pressure, it overworks my heart and shortens its timeline and mine as well. Now, I don't need to get too in the weeds as far as acidosis and alkalosis, but you should know essentially that even though we're not breathing, there's a lot of other things happening. I don't really need you to know much about it other than if I go into cardiac arrest, basically I'm in a state of respiratory acidosis. If I'm not ventilating, I'm storing up my CO2. It's putting me in acidic state. Quite frankly, that's all you need to know. Hypoventilation, respiratory acidosis. If I'm not breathing out my CO2, acid builds up in me. If I pour acid on your hand, does it destroy the cells? Yes, it can. It's strong enough acid, right? So therefore, if you're not ventilating, your body creates an acidic situation. All right. Just know that in our chest traumas, we can have essentially blunt or penetrating. The blunt one is the tricky one, I think, in some ways. I think sometimes we see ecchymosis on the chest and think, oh, no big deal. But we got bones in there that might break. We got organs that might contuse and tear. That would be a problem. So we'll need to be able to differentiate these things based on what they look like. Have an AED close if you've got a person with severe chest trauma. Have an AED close if you've got a patient with severe head trauma. Now, I didn't make a mistake in learning this, but I remember that there was a portion of my career I didn't think this way. I had a guy that came in, sorry, it was a different truck. They'd come in, dude had shot himself in the face. And he wasn't in cardiac arrest. He was alive. He probably was never human again. But he came in, and I remember seeing that they had their AED on him. And I was like, whoa, did he go into cardiac arrest? And they're like, no, but he shot himself in the head. I just had a suspicion it might be around the corner. And I thought, right, I need to start thinking like that. That is very wise, right? And so we want to think that way. I'm not saying every seatbelt sign, you know, every time I see a little bruise here. What I'm saying is if I've got a major chest trauma, it might be wise to have an AED close. Rossi?
When we do CPR, we break the ribs, right?
No, you break the cartilage attaching the ribs to the sternum
Okay.
when you do CPR.
Yeah, I was gonna ask, don't it cause like potential cardiac or like any trauma to the lungs?
You can cause a lot of trauma. It's definite. I've had a couple of situations where first responders got on scene. They thought an overdose was cardiac arrest, so they started doing compressions even though the guy was just ODing on something. I show up, give a reversal agent, he comes back, but I'd done CPR, and they're like, God, why is my chest hurting? Because I'm good at CPR, brother. Like, it's going to hurt. It's going to goof up your heart, goof up your lungs, maybe break your cartilage, absolutely. But it's arguably better than death, so that's why we do it. So we need to be mindful, again, not just of like, oh, there's a bruise, oh, there's bleeding, but really it's our breathing chamber, this thoracic cavity. We have to consider how this might affect gas exchange and how this might affect our ability to ventilate as well. Now there's all kinds of various signs and symptoms that will appear here. DCAP BTLS, DCAP TLS if you nasty, perhaps. Certainly pain in the chest is a way of indicating that, but so too is trouble breathing. And boys and girls, if you aren't already, you better be on this circle of, hey, so I heard you had chest pain. I'm gonna ask you, or do a heart investigation. Okay, turns out I don't have anything there. Now I'm immediately investigating your lungs because you said chest pain. Oh, you got trouble breathing? I'm gonna listen to those lung sounds almost immediately and do a lung investigation. Then I'm gonna start doing cardiac questions. Why? Because they're all in the same place and they can all look like each other. Chest pain, difficulty breathing, right? What is crepitus? Right? It's essentially the sensation of broken bones, right? Hemoptysis, what word do I want you to say if I say hemoptysis? We're not there yet. Nope. Well, where are we at? TB, tuberculosis. If you get a question on the registry about hemoptysis, dead to nuts, the answer is tuberculosis. It's not the only thing that causes hemoptysis, of course, but buddy, I'll bet you that's it. Why do you think that the National Registry wants you to know and have a strong association and suspicion of tuberculosis? Good job, Emily. Gage? Yeah, because they want you to know that it's not just a cough, so you don't wear just a surgical mask, you should have an N95 on. That's why they want you to know, because they don't want you to get it, they don't want you to die, but even more importantly, they don't want you to spread it. What would asymmetry, an asymmetrical chest rise and fall indicate? Right? We said collapsed lung before pneumothorax, there we go. Or maybe a pneumothorax, hemothorax, that can be it. Anything else? What? Trauma in the chest, yes, we're getting closer. Flail chest. I'm glad you said that, because no one else did. We'll talk about circulatory collapse and pulsus paradoxus in more detail. Pulsus paradoxus is a fancy way of saying that when you breathe in, your blood pressure goes down. Can anybody help me understand why, if I take in a deep breath, my blood pressure might go down? Trying to get more blood to the lungs, so it's like a diversion thing. That's a good thought. Not no, but that's a clever thought. Very clever thought. The pressure, right? Is I take in a deep breath, I'm always careful to say this. I don't want to say increasing the pressure. I think technically decreasing, which is a pressure change. The point is the deeper my breath is, the more pressure change is happening, and then the compression of my heart and vessels is occurring. Think about it like this. If I take in a deep breath, I'm lowering the pressure, right? Because it's negative in my thoracic cavity. So then air rushes in, And now I have a higher pressure gradient pushing against my heart in the first place. Or put pretty simply, when you take in a deep breath, your blood pressure will go down because there's more pressure in there. Now that's a normal process. Like if I could somehow, put on both of a person's arm at the same time and check it, and let's say all things were perfect, like maybe at an arterial, it would be pretty normal to see that we've got a change in blood pressure, but it becomes pulsus paradoxus in a pathological sense if there's a major shift greater than 10. What this ultimately suggests is cardiac tamponade. What is cardiac tamponade? It is pressure on the heart. What is the sac that's surrounding the heart called? It's not pleural, right? Pericardial sac. Yeah, that's right. Make sure you use the list. It's the pericardial sac, right? Absolutely. Whatever gets you to remember. Now, we're going to talk a bit about backboards specifically. Put pretty simply, if I asked you, hey, when do we use a scoop stretcher instead of a backboard, what might you say? I don't know. He said, I like that one. Put pretty simply is that the scoop stretcher is largely for people that need extrication, not spinal immobilization. Like if I've got somebody on the ground, they have a broken femur maybe, well, I'd probably use a backboard still for that. We often see it used with pelvic injuries because we don't want to wobble them around too much. We just unhook the scoop stretcher and put it on either side of them. Now, it's not absent of spinal motion restriction. It's basically, I'm going to opt for a scoop stretcher over a backboard when any of these things, not any of these things, none of those things are listed, when you have penetrating trauma to the thoracic cavity. If I show up and you got stabbed or shot or anything like that in the chest or head, I'm going to use a scoop stretcher, even if it's a spinal precaution patient, because those things kill you so fast that it's not worth putting a person on a backboard and risking it. So, if I get a guy that gets shot and then falls, does he need a backboard? Yes. If he got shot in the chest, then I'm going to use a scoop stretcher. Does that make sense?
Yeah.
Great. We know this already, that our neck injury assessment includes both a midline trachea assessment of JVD and what we'll soon discuss, flattened neck veins as well can be a good indicator. And also cervical step-off. We'll get through this next break. Take a break. Now, technically, jugular vein distension is measured when people are setting up at 45 degrees. Technically. Because if a person lays flat on their back, they should have JVD, because their blood is so used to having to pump against gravity at upright position that when you're laying flat, it is normal to have JVD. Which is why we put them at a 45-degree angle to look for it in the first place. Now, I'm glad that you all know JVD. We know that it goes at a 45-degree angle. It is often a first visible sign when we have a thoracic obstruction problem. It is, in my experience, very difficult to determine whether or not your patient has JVD for realsies. Now, it's a good thought process. It's a good pertinent negative. My patient was complaining of chest pain, difficulty breathing. I noted no JVD. That is an excellent thought process, and it's a really good pertinent negative. But again, as always, we have to use these as rules of inclusion, not exclusion. I didn't see JVD. Well, that might not mean we're out of the woods yet. But if I see JVD, then I'm pretty sure I know what this is. Right? If you think about it, jugular veins are blood returning back to your heart. The reason they're becoming distended is because there's a backup at the doorway. I mean, we distend veins in the arms when we're doing IVs. I wrap a tourniquet around your arm, it distends your veins. Why would I want distended veins when I'm trying to do an IV? Because it's easier to stick. Big fat ripe boys. Bite into them like apples. Arr. Absolutely. But again, generally speaking, this should be a sign for us that blood is not returning to the thoracic cavity. I found a picture of this. Here's some JVD. I have almost never seen that in the world. Sure, it'd be nice if this patient essentially had a pneumothorax or something, and then I saw that. I'd be like, well, yeah, obviously, but that's not often the case. But that clearly is what is going on there. Now, make sure you know this. This is one of the big giveaways here. JVD is a strong early indication of a tension pneumothorax. It will be your job. In fact, your superpower really as an EMT is early identification. If you didn't know what you know now or soon will learn, that, hey, no ma'am, I'm telling you, you don't just have chest pain. Based on the presentation of your veins, I'm saying we have to leave immediately. You die from this soon. This isn't just chest pain. And I can tell because I know a thing or two about veins. Basically, we'll talk about how pneumothorax is air in the pleural cavity collapsing a lung, but the tension we're talking about is not on the trachea, it's on the heart. As the pneumothorax gets worse and worse and worse, it puts more and more tension on the heart, and that will kill you. And one of the earliest signs you'll see is JVD. Little wrap there. Take a quick break. So, JVD should be a strong indication that blood is not able to get into our thoracic cavity. It might mean that it can't get in because of our heart. It might mean that it can't get in because of a vasculature in our lungs. But what it definitely means is that blood can't get into our thoracic cavity. And so the presence of JVD is a strong indicator and a narrowing down these things here. I.e., if I said, hey, your patient has JVD, what should you suspect? You'd say, maybe cardiac tamponade, tension pneumothorax, or pulmonary embolism. Simple as that. Now, jugular vein flattening is the opposite issue, right? Instead of it being distended, they're flat. And put pretty simply, we're going to get jugular vein flattening because we don't have enough blood to fill the veins at all. This is one that I'm 100% sure I've never seen, or at least that I've never taken note of. It's not hard to tell the difference. One looks like a balloon, the other one you can't see. Where this would take place is essentially you laying a patient supine, and they should have JVD because when you're supine, that blood should be pumping pretty good up to the neck. If you lay them flat and don't see any JVD, then you're like, oh, these neck veins are flat. The issue is that I think it's unreliable clinically. Now, if I tell it to you in a test, then that should get your noodle cooking as to why or what is happening. Why would it be? What is a hemothorax, first of all? Blood where it shouldn't be, in the thoracic cavity, and more to the point, in the pleural cavity, which is compressing the lungs first and then eventually the heart, right? Right. So a hemothorax is just a pneumothorax, but blood instead of air. Again, in testing world, I'll be making these distinctions. You'll be saying things like, oh, if they got flattened neck veins, that means hemothorax. Why would flattened neck veins be more hemothorax than pneumothorax? Say it again. Volume issue. Because if I've got a bunch of air in there, the pressure is high, so the blood can't return. That's JVD. If I've got a bunch of blood in there, I know the pressure is high, but all the blood that would be distending the neck veins is now in the chest, so they might be flat. The problem, again, why I say that the reason why I say, okay, this is testing stuff. Make sure you know that flattened neck veins are more indicative of what? Hemo or pneumo? Hemo, because all the blood is filling, right? And JVD is more indicative of what? Pneumo or hemo. Okay. The problem is most people have both. If you got some kind of damage to the chest that caused a pneumo or a hemo, usually it's causing the other one. So it's a little difficult. Like if you got in the field and said, boom, I know this is pneumo because I can see JVD and it's not flattened, I'd be like, cool. That's going to work really well on a test you're going to take tomorrow. It will not serve you super well out here in the field because he's probably got both.
So you just suspect those on the field?
Yeah, the problem is the reason why we can teach you to differentiate is it's good critical thinking, but also there is no treatment that differs from between the two. Even as a paramedic, as we do a needle thoracostomy or a dart their chest to let it out, it doesn't matter whether it's a hemo or a pneumo, it's both got to come out. So being able to differentiate them is not super relevant.
So it doesn't matter the problem, the solution's the same?
Yes, largely, at least for us. Yeah, it doesn't necessarily matter what the problem is. The solution is the same. I think that was well put. Except for on a test where it definitely matters. Yeah.
What's the solution?
The solution is to get it out. As an EMT, vitamin G. Yep. Gasoline, we drive to the hospital. Yeah, he's like, okay. 2 pills, vitamin G. No, you got it. Guess what it is for an AEMT? Same thing. Guess what it is for a medic? Yeah, we can say that it's a needle thoracostomy. Those things are highly ineffective in many ways. What he needs is a chest tube, where this is a chest tube right here. Okay, it's missing the stylet, it's missing the pointy part, but it's a giant tube. And literally, some fancy doctor, I bring them in, they got JVD, tracheal deviation maybe, it'll just take this and just right up in your ribs until all the stuff leaks out. Neat. It's super cool. But my point is that that more important than a needle thoracostomy, more important than being a paramedic is being able to know what's happening in the first place. Right? The difference of that is the discussion that we're having. I wish I could record our conversations and then you come back in a year and you're like, I cannot believe I made the case that I should put on this traction splint before oxygen or whatever. I'm like, how do you know that? Well, because I watched 2 people die when I waited. I'm like, well, that'll do it. Nothing teaches like failure. So again, the difference is, you might say, well, okay, if I'm not doing any treatment outside of transport, then what's the big deal? Why we differentiate? I mean, because we need somebody on scene who says, hey boys, this is a problem. This isn't just a guy who has a bruise on his chest. Look at how he's laying. Look at his neck veins. We gotta go, and we gotta go now. And we gotta go to the right place, because if we don't leave soon enough, and if we don't go to the right place, then they definitely die. And you might say, well, there's no treatment for that in the field. I say the treatment is the identification. That's the point. So make sure that you're exposing, inspecting, and palpating. Like I said, next year when we do this detailed head to toe, which you, by and large, did amazing on, by the way. I mean, just really, really good. Really appreciate that. Is I'm going to put words on it, right? Tape on the bicep, tape on the underarm. I had a lot of students come in and say, well, I'm going to check anterior and posterior, and then only rub down the anterior. I'm like, well, it doesn't work that way. When you go into your graded practical, be looking for that kind of stuff. Don't verbalize, well, obviously I check the top and bottom of everything. No, check everything. If there's an injury hidden in there somewhere, you're going to have to be able to see it, right? So we're looking for life threats. We're looking for decap BTLS. We're looking for adequate chest rise. We're looking for adequate chest fall. I wonder how much we can play in this. Why is it important to note adequate chest rise?
To make sure that there's actually air coming in.
Air coming in so that they're getting oxygen. Why is it important to note adequate fall? Woo. That's cool. That's cool. Good job. Because CO2. Why is it a problem if CO2 doesn't come out? Jesus! Because of acidosis. We're going to do just fine. AMT is going to be a hoot, guys. You're going to love it. It's going to be amazing. Oof. I was in a long conversation with an instructor recently, and they were talking to me about EMT, and they're like, man, I'm having trouble like figuring out exactly what to tell them. I'm like, my problem is figuring out what not to tell them. That's why. There's a reason why we have a fantastically high success rate on the AEMT, because we start AEMT day 1. With impaled objects, these require immediate stabilization. You arrive to find a patient laying on the ground. He's got a knife sticking out of his chest. Are there any life threats? Yes. The knife sticking out of his chest, even if it's not actively killing him, if he twists the wrong way, it will, right? And so what we want to do is to walk up, see a person with something stuck out of them and just say, hey, my name is Steven here. I'm going to take care of you, but I got to hold on to this. Don't move, okay? I don't want this to move. Or I assign someone to it. I'm like, hey, what's your name? Alicia K. That's your whole job now. Nobody pulls you off of this. That's your whole job. Nobody bumps it. Nobody twists it, right? I definitely don't want my rapid transport to turn into a cardiac arrest because somebody didn't hold the thing in place, right? Be careful you don't cut yourself and all that. But again, it's a life threat even if it's not actively killing him. Check ABCs afterwards. Do we know what an open pneumothorax is?
Not necessarily a sign.
Some good answers, and here's some good answers for sure. A pneumothorax is air in the pleural cavity collapsing the lung, yeah? An open pneumothorax means there's a hole in our chest. You could have a closed pneumothorax. That would just be air on the inside compressing. But an open pneumothorax is your sucking chest wound. That's the one that needs it's the gunshot. It's the hole in the chest. Now, what I'm saying is the order of operations for this is, do I see any life threats? The adjunct, if you could see it, would then say, yes, you see a wound on the chest with bubbles coming out of it. Now, truth be told, sucking chest wounds usually have to be like around the size of a $50. They got to be kind of huge before they actually require occlusive, but we're going to make you put occlusives on anything essentially neck to something else way down here. What's that? Pelvis? I think I've just never found a good reference point. I'm going to get a tattoo or something that just says occlusive above here. I don't know. In any event, make sure that when you see this, you apply an immediate gloved hand. Why am I applying an immediate gloved hand on open pneumothorax? Because it is an occlusive dressing, isn't it? Right? And it'll do its job. Right? Just wad up that glove, stick it in there. Don't do that. Evan?
How often is it that services nowadays don't have specific occlusive dressing?
I've never worked at an agency that had a chest seal. What I usually do is I'd use the inside of an IV bag. Just cut it open, put it on the chest, boom. I think sometimes you forget how new our career is. Now, I would love to be delighted to find out you went out and to work at all the local EMS agencies and they all had chest seals. Here's my suspicion. Number one, the science does not support that any occlusive dressings help anyways. Now, if they know that, they're probably not going to spend all the money on it to help them. My experience of using occlusive dressings is wipe, 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 wipe. I'm like, okay, wait, we just got to make a decision here, right? And just put the occlusive dressing on. So they're not proven essentially to do necessarily what they need to do, or at least reduce mortality. But we surmise that it'll work, and we can prove that it is. Okay, let me be clear here. We can prove that it is stopping air from going in and out. We can prove that. What we're not proving is that it is in any way improving their outcome. Anyway, the point is any occlusive dressing is something that doesn't allow air to go through it. Chest seals would be nice, but I've never worked at a place that had them. This is probably one of my favorite things in your book, The Deadly Dozen. It's like a Quentin Tarantino movie. I thought this was so cool. When I saw this, I was just like, that's it. Holy cow. Like, these are the things that we need to know. Now, I think some of them are a little unnecessarily deep water, but we'll talk about a lot of these. Heck, I remember when I had, well, we haven't done anything with IOs, so maybe this won't surprise you, but most of my career was done using manual IOs. Like, IOs now are done intraosseous. Are we familiar with these things? I don't know how, okay. Essentially what it is now, little gun, little drill. Let's see, IO drill.
Like y'all have to do like a corkscrew? It's an emergence and into the bone marrow, which is very vascular, through which you can administer life-saving medications. See, you do not have an IV, or there is no time to get the IV. You're going to drill a hole in the bone. This is called intraosseous access. This goes directly through the bone and into the bone marrow, which is very vascular, through which you can administer life-saving medications. This is painful as heck. You do not want to do this on an...
I'll tell you this though, when you push fluid into it, that hurts for sure. Displacing marrow, not super fun. But most of my career was spent using a little T-shaped piece of metal where I did that with my hand. And let me tell you, when I was working in Flint, we would used to have a bunch of special forces guys come through because we got a decent amount of trauma. And so they'd put these guys on the ambulances to experience the trauma of the city and stuff. And I had this dude once who was unconscious in a car accident. He was laying, I say, hey, can't get a line, this guy's all mashed up. I said, you wanna go ahead and do an IO? He said, no problem. So he grabbed it and he put it on this guy's shin. You're just supposed to kind of put some perpendicular pressure where you twist and it goes in. I don't know if this guy had never done one or didn't understand how it worked, but this guy that I was assessing was unresponsive. And then he put this IO needle on the dude's shin and tilted it slightly. And when I tell you he went from kneecap to toe, I am not kidding. He drugged this IO and that man came up off the stretcher like a zombie. He lurched up, he just, boom, back down. Never saw him move ever again. I was like, yeah, I don't think we can call that responsive to pain. That was a new, we definitely are not, bent IO needle and stuff. I was like, okay, we're gonna have a powwow about how this is done. Rossi. It definitely was. But he was so low on blood, it just was a rip. Just a tear like somebody tore through a sheet, yeah. We do those when I can't get IV access and I still need to give you intravenous fluid or medicine. You can go through the bone and it goes right into the blood system.
How often are you able to bring your own stuff from home? You mentioned a scalpel earlier.
How often are you able to bring stuff from home? I'm assuming medical equipment. I don't really know. I mean, there's a certain amount of stuff you technically need medical authority to use in the first place. And I will say this, if I'm going to court and a mistake was made, I want it like sanctioned equipment from but probably you can bring a decent amount of fundamental stuff, but you just make the company pay for it.
Yeah.
Do you mean like a chest seal?
Chest seal,
Yeah.
scalpel, anything like that.
I don't think it's ever going to be an issue. Unless it was an issue, then it would be a big problem. Like this person develops sepsis. They find out you brought your own scalpel, It's like, have you used it before? Was it? Yeah, it was sterile. Okay, don't bring stuff from home is probably the best idea. But again, I don't think anybody's getting in trouble if it worked.
Right.
Airway obstruction, make sure, did I miss any questions in there? Airway obstruction, make sure that you remember that we are doing, did we teach you this in BLS? Back blows? Okay, all right, team. All right, team. If they're coughing, we talk back, right? If they're not coughing, then we do back blows. Is that for adults or infants? Both. Then we do abdominal thrusts. Not for infants, though. What do you do for infants if the back blows didn't work? I do back blows 1, 2, 3, 4, 5. Flip them over and do chest thrusts, kind of like compressions, right? But I'm not really doing compressions until that child, what? Unresponsive, right? And that's the order. Okay. Deviation, this term deviation means shifted. We can deviate. If you put your finger on the outside of your trachea right now and push hard enough, you're going to deviate it. It's going to change the way your voice sounds. Right? Some of us talk on the phone that way just so we sound like a real man. I just squeeze it. 2 large pizzas. All right. Okay, disruption is not deviation. Disruption is a tear. Disruption equals rupture. It should be called disruption. Yeah. So make sure, this is a common misconception. We'd be like, yeah, patient has tracheal disruption. Okay, well that's kind of an issue. I'm like, no, it's not an issue. It's peri-arrest. If you got a hole in your trachea, you die in seconds. Now, this can be tracheal or bronchial, this disruption, but you can also have disruption of really anything. Disruption of the aorta, for example. Somebody paint a picture for me. You have a aortic artery, the biggest artery you have coming off of your chest. I said this patient's got an aortic disruption. Paint a picture for me. Yeah. What are you envisioning? Right? Just to sound like this, right before he dies. So, an airway disruption, this is usually caused from major trauma. This isn't like a guy got an infection and then suddenly tore his trachea. No, this is our fella hit his neck on the edge of the stage when he was crowd surfing or something. This is a guy fell off of something, get flung from a vehicle. Anybody surprised to hear that we would expect severe respiratory distress? Good, great, we're on the right page. What about subcutaneous emphysema? Yeah, air underneath the skin. Why would a guy with tracheal disruption have subcutaneous emphysema? That's right, yeah, I appreciate the eyebrows. Because air goes in the skin? Yeah. We'll see when test time comes. I got a question. The question is, you got a patient experiencing tracheal deviation, what should you suspect? And like 4 people are gonna be like, subcutaneous emphysema. I'm like, no, that's disruption, not deviation. Traumatic asphyxia is a compression injury, a crush injury. It's not crush or compression syndrome. Let's just add another C to that, right? Basically what I'm trying to say is this is sudden increase in thoracic pressure, right? This is you getting hit by a car or getting pinned by a car. Basically it's, you ever seen those little stress balls where they've got faces and eyes and you squeeze them and their eyes and stuff come out? Okay, that's this. You just get squeezed where all of a sudden it's like, hey, remember how your blood pressure is like 120 at the max? What about 4,000 right now? Right? No. Well, it depends on the person, but it's ultimately not the greatest. Exophthalmos. You know exophthalmos? I don't think so. It's
Outside of the thalamus?
bulging eyes, that's what it is. I was trying to find it. There we go. Boom. There's some exophthalmos. But like I said, it's those stress, right? You see what I mean by the squeezy balls? The ones with faces? Exophthalmos. Boom. That's right. Graves' disease, good job. I have no idea. Oh man, I forgot what the name is. There's a intervention that they will do when you have too much pressure there, where they go in and they snip your eyelid to, oh, it was the most horrific thing I've ever seen in my life. Rossi.
What if you like encounter someone whose eyes are like naturally like that?
Well, some people will have eyes that are naturally bulging, and sometimes, I will say this, I would ask them, we'll get into it when we talk a little bit about endocrine essentially, because exophthalmos is a bulging eyes secondary to a thyroid condition. You know, but I suppose depending on where you're living, you can be careful how you ask that. Okay, here's what you need to do. You need to be able to differentiate spontaneous, simple, and tension pneumothorax. Yonk to. Spontaneous, simple, and tension pneumothorax. Generally speaking, spontaneous is a medical problem and simple is a trauma problem, generally speaking. If you said, Mr. Fearon, how do people even get spontaneous pneumothoraxes without ever getting trauma? I'd say it means their lung tissue is weak in the first place. Spontaneous pneumothoraxes happen when, well, let's talk. Simple pneumothoraxes, the explanation is simple. There I was, and so was the tractor, right? I started a joke with my wife. I said, what do you tell a woman with 2 black eyes? I finished the joke. Boom, simple pneumothorax. She stabbed me to death. A simple pneumothorax is generally, that's when I have normal lung pathology, or sorry, normal lung physiology, and then something extraneous happens and it causes a pneumothorax. Spontaneous is normal stuff happens, but I have weak lung tissue and that causes the pneumothorax. Open pneumothorax is a different situation because that's a hole in my chest. You're not going to get a spontaneous open pneumothorax. Okay? Now the term bleb is essentially when you have these alveoli that are disfigured and deformed, they're weakened walls, and they find themselves prone to tearing. If you get a tear in enough chunks of alveoli, air will escape, it will fill the pleural cavity and cause a spontaneous pneumothorax. Now a tension pneumothorax is what you need to be mindful of. Yes, this might be a pneumothorax, but I'm watching for signs that it's becoming a tension pneumothorax. You die from a tension pneumothorax. In regards to a pneumothorax and a hemothorax, I'm just going to continuously say pneumo, but I almost always mean both, or either or, almost always. With a spontaneous one, this might be as simple as coughing, walking up and down the stairs. Then I had a sudden onset of shortness of breath. You auscultate lungs and find unilateral sounds. That's weird. How on earth could this person have a pneumothorax without any trauma? Well, because they probably have some pre-existing lung condition. With a simple one, we're going to start to suspect obvious or perhaps major chest trauma. Yeah. I don't think so because, well, yes, it can. It absolutely can. Can tuberculosis cause it? I was going to say, no, it wouldn't cause it because these are usually from chronic conditions and pathology, but yeah, actually all at once it could. I don't know. I guess it would probably still be I would guess spontaneous because of that. I don't know that this graphic helps you, but a pneumo can be spontaneous or simple. You can get a pneumothorax spontaneously or from simple. You can also get a hemothorax from both. But my big point here is, number one, open is always simple. You won't get a medical blowing out of the chest. I suppose even if you had an alien in you, we'd still call that a simple pneumothorax. But they all kill you by tension. Spontaneous can become tension pneumothorax, simple can become tension pneumothorax, and open simple can become tension pneumothorax. When I say tension, what am I talking about the pneumo putting tension on? The heart, which is going to do what? Cardiac tamponade is a heart issue, not a pneumothorax issue. But I mean, it's going to reduce blood pressure. This is obstructive shock, right? Tension pneumothorax is obstructive shock. Now, we definitely know we want to put oxygen on a person if we think that they're experiencing a pneumothorax. We don't wait for a tension to develop. We put air on them immediately. You might need to assist their ventilations. I definitely don't want to regret saying this. If you left this career saying, oh, we only ventilate people who are unresponsive, I'd say, okay, sure, that's almost always going to be true. You can BVM people who are responsive, but you're going to count on one hand the amount of times you do that in your career, I can guarantee it. We are not often BVMing people. Now, what I can say is this, listen to your patients. If you go to BVM somebody because you think they have a pneumothorax and we're trying to do what we call internal splinting, I'm just going to breathe with them to help inflate their lungs against the developing pressure, right? Listen to them, right? If Emily's bagging me as a patient, she says, sir, I think you're having a pneumothorax, you're not taking a deep enough breath, and so she's going to start bagging me. Go ahead. Go ahead, tell me though.
I'm gonna bag you, okay?
Why?
You forgot.
You're not taking a deep enough breath.
Oh, my chest hurts. You want to bag me? Why?
Because you're not taking a deep breath.
Okay, so it's going to help me inflate my lungs and stuff?
Yeah.
Okay, go ahead, go ahead. Oh, God. Oh, God. I hate this. Okay, listen to them. You would not believe the amount of times they're basically just putting a pillow over their patient's face, being like, shh, I'm a medical professional, be still. I'm like, look, I understand that working a cardiac arrest is the simplest algorithm, but it's not where we should be rushing to each time. If you're bagging a patient, don't tell them, this is gonna fix you if they're losing their minds over it. Be mindful of that. Can somebody tell me why, even though I might supply ventilations with a BVM, if I've got a person that I suspect is having a pneumothorax, why might it be unwise to put a CPAP? Why is it a contraindication? I believe you. Touch your nose. I believe you as well. Oh, well, that's okay. Rossi? I know, that's why I just called the first one, because I was like, wait, now when I call on somebody, I'm like, oh, I don't think you know this. Yeah, go ahead.
BVM is like, I mean, the CPAP is like constant BVM, like always.
It's constant BVM and it's high pressure. T, Evan, you got more? I don't know anything about that, so I'm not sure, Evan.
It could be pushing air.
If you have a hole in your lung, if that's what's the pneumo is caused, then putting high pressure, continuous high pressure from a CPAP is definitely going to kill you. Gage? It is. Yes, absolutely it will. That's the tension pneumo. That's what's going to kill you.
Didn't you say we could do it for pneumothorax?
No. Someone might have. I definitely wouldn't. Generally speaking, if I think you have, because, do you know why I think that? Or I'll just cut to it. Because if I suspect a hemo, I'm also suspecting a pneumothorax, you know? So there's no way. Now, our signs of pneumo is altered mental status. Give me an example of what that looks like. What do I mean when I say altered mental status? Confusion, anxiety, restlessness, right? Huh?
50 quarters in the belt.
Sure. We have to be mindful. If I listen to lung sounds and I hear unilateral deficit, where one side is wrong, I'm starting to think they got a pneumo, but now I'm watching. Is their heart rate going up? Are they starting to fight harder? Are the respiratory rate going up? If I got an occlusive dressing on, these are the signs I'm looking for before I'm allowed to burp the injury. Because an occlusive dressing will work. If you've got air building up in your lungs and you put it on your chest, it will force the air to stay in there and continue to build up a pneumo. That's not great. If I start to see that patient getting weaker, weirder, or their heart rate and respiratory rate or sudden onset of increasing dyspnea, I'm going to have to ventilate that, let a little air out. But just don't fan it, right? You'd not believe the amount of times essentially students are like, okay, we got an occlusive, we got to burp it, okay, here we go. I'm like, no, we don't just burp arbitrarily. It's there to keep air from going in. If you keep burping it, you're just putting air in it, right?
So do you just burp for the patients who they feel like a relief, or you just burp?
I've never noticed a change occur. It's like when I see tachycardia starting, when I'm like looking at their heart rate, it's 100, it's 110, it's 120. I'm like, okay, let's go ahead and give that a little burp, whatnot. Then we'll put it right back. I know, so it's like, I can't breathe. I'm going to open it. I don't hear an escape of air. I've never seen a rush or whatnot. We give it a little gas, off gas, and put it right back. Well, here you go. Boom. Both the pneumothorax and hemothorax can occur 80% of all cases in penetrating trauma. I don't remember where I pulled that from. It's probably in the notes, but that's my point, is that they often occur in tandem, so be a little careful. In testing world, it's going to be helpful. JVD, flattened neck veins, boom, easy. One is hemo, one is pneumo, you got it. In the world, though, like I said, open pneumothorax. This is your sucking chest wound. Now, you need to talk to the adjuncts and you need to think to yourself when you see chest wound, is there air escaping it? Now, we eliminate that, that decision making from you. I'm like, dude, if they've got something between, what do we decide here? I don't know, groin and neck, from the tattoo to the neck. Essentially, we want an occlusive dressing. Don't overthink it. Now, I'm going to teach you this 3-side, 4-side thing because it's the technical right answer, but I don't care in here. I won't have a test question on it where you have to differentiate the two, and I won't have it in a practical if I do so. Generally speaking, we want to tape 3 sides of an occlusive when it's near your airway, or sorry, where your lungs are, because we're going to want it to self-vent. And 4-sided if you're using an occlusive dressing somewhere in the neck or the abdomen where there's going to be less likelihood of air movement. That's the technical right answer because we want that one completely occluding and the other one self-venting. My experience is It doesn't usually stick in the first place, and the self-venting thing is nonsense. So I don't ask you those questions, but if the registry does, that's what you need to know. Again, burp with signs and symptoms. Don't just periodically do it because you think it's a good idea. Do it when you have evidence. Paper bag syndrome. Can somebody summarize for me why we're getting a paper bag syndrome?
Because a lot of people like take a deep breath.
They do, so air rushes into our lungs, but why isn't it just coming out when I get squashed? Yeah, your larynx, essentially, your glottis is closing, right? So you bring in a bunch of air, you close the top of it, blammo. So this could cause a what kind of pneumothorax? Well, they all go to tension eventually. Well, I don't know that they all go there, but that's our concern, right? Simple or spontaneous? Simple. Spontaneous would be normal process, pathological lungs. A simple pneumothorax is normal lungs, pathological process. But both would have been an answer that's correct if you said we're thinking hemo and pneumo. All right, take a quick break. One of our earliest signs of tension pneumo is jugular vein distension, right? It's blood not being able to return to the chest. It means that not only do we have air in there, we have so much it's squishing the heart. Compensation will become decompensation eventually. You'll see their heart rate go up, you'll see their respiratory rate go up, and then you'll see them go over the peak of that compensation triangle and everything will start going down. You'll see cyanosis perhaps. Why would you get resistance when bagging somebody with a tension pneumo? Because it's pushing against the pressure to expand, right? Bingo. What is what? You say it again? What does it mean?
No, I was thinking oppositely my belief.
Okay. You're healed. Tracheal deviation. I've made it a point to talk about tracheal deviation last, because here's what happens. People always associate tension pneumothorax with tracheal deviation, and you shouldn't do that first. You should assign JVD to tension pneumo. This is waiting for tracheal deviation, meaning your trachea deviating because your mediastinum is pulling so hard due to pressure. Waiting for tracheal deviation is like you saying, we don't need to treat for shock yet. His blood pressure is not low. I'm like, if you wait for that, he might die. So if you wait for tracheal deviation before you start considering this as a pneumo, you're in big, big trouble. Yes, you. Okay, I don't want to talk a ton about this. I'm definitely not teaching you how to do this, but I do think it's simple enough to remember. When you're assessing a chest, you can technically tap on your fingers listening for high-pitched sounds or dullness, and these will help you differentiate whether or not there is fluid or air. Now, I'm not going to teach you how to do that. I'd love to be there when you try in an ambulance 90 miles an hour down the road with a guy dying. But the reason I bring it up is you can see it as clues in tests. It'll say something like your patient has flattened neck veins and tracheal deviation, and hyporesonance, what should you suspect? Well, if you couldn't get it from the flattened neck veins and the tracheal deviation, hypo, the O in blood, hyporesonance, the dull sound when you tap, indicates fluid in there. Hyper, air. If your patient is positive for hyperresonance or high-pitched sounds, we want to consider air is in the chest. What up? Pneumo versus hemo. Yeah. Okay, flail chest. Our definition of a flail chest is 2 adjacent ribs in 2 or more places. The thoracic cavity is like a cage that's keep allowing you to drop the pressure in your chest so that air can rush in. If you have 2 adjacent ribs broken in 2 or more places, it's going to pull in when you suck in instead of pull out. It's going to be the opposite. Paradoxical. Is she not on there? Okay. Paradoxical is opposite. It means flail chest. We might use internal splinting. We might say, hey, look, I'm going to put this BVM on your face. It's going to help you with your pressure here. You're not really ventilating them so much as helping support them, because they're going to be guarding and they're going to be potentially hypoxic because there's so much pain when they breathe in, and we're just going to help their lungs expand without moving their chest. See what I'm saying?
So we're applying pressure?
Inside the lungs as opposed to pulling against the chest, which is what the body does.
Okay, so would a CPAP
Is too much pressure.
too much pressure?
Yep. With a BVM, we're not doing manual ventilations. It's just that they have to use their chest. We all have to use our chest to breathe, and they're not going to be able to do that because it hurts really bad and the structure is destroyed. So if I can use a BVM to apply positive pressure instead of relying on their chest creating negative pressure, then it can help them. What I'm trying to get at here is if you think of flail chest and the guy's hypoxic, you might want to try a BVM. Now, I'm not bagging him at 10 times a minute. I'm just supporting his ventilations and giving him that extra inflation, trying to improve his pulse ox. Evan?
So you're saying don't CPAP for a phone?
Oh, sorry. Is that what you were asking?
Yeah.
Oh, I'm so sorry. No, CPAP is okay for flail. It's not okay for pneumo.
Because you said...
I'm so sorry, Moaz. You were right. Yes, CPAP is okay for this. Now, the only asterisk to that is guess what? You can get pneumos from flail chest, so you have to be mindful of that. But yeah, it's not a contraindication for that specifically. It's a contraindication for pneumo. It's just that when you have 2 or more ribs broken in 2 or more places, well,
You wouldn't want to risk it.
well, I'm not. BVM is probably going to get you what you need. And I have never CPAP'd a suspected paradoxical movement, but it can be done. Usually BVM gets me there. No external splinting. I put that because we used to teach sandbags. We used to teach, hey, we're so suspicious of you getting a pneumo from it. I need to put a sandbag on your chest so that piece doesn't move, or else it's going to poke your lungs and cause a pneumo. We don't do that anymore because they weren't always getting pneumos, and it turns out putting a heavy object on somebody who can't breathe very well isn't great for them. We're learning. We're learning. Why would we call paramedics for this patient? This is one thing that we should really start seeing. I should have an intervention card on it. All the card says is ALS. Indication. It's a patient that's sick.
Anything out of our scope.
Yeah, because, if I get a patient here, first of all, I'm probably giving this guy fentanyl or morphine. Because if he's in less pain, he's going to pull against his brake more. That's what I want. I want him.
You, not us.
Yeah, me or an AEMT. But what's interesting is we move into trauma and stuff, and as we develop our career, we need to almost start thinking of calling ALS like an intervention, because basically what happens, that's why it appears twice on your patient assessment, is because people are like, I'm going to go ahead and consider ALS. Anyways, runs a 20-minute call, never calls them, never thinks about them ever again. I'm like, whoa, dude, they can fix some of this stuff, or at least make it easier and safer. Even if they can't get to you, you definitely need to be on record as calling them. Okay, all I mean to say here is that we need to pay attention to this stuff. We're noting rise and fall, we're noting increased heart rate and JVD. What would happen if I said your patient has a known flail chest secondary to a blunt trauma? We know they have a flail chest, you can see paradoxical movement, and then you notice they're experiencing increased respiratory rate, increased heart rate, and JVD. What should you suspect? Tension pneumo. Pneumo and because a tension pneumo means it can't get in there, and pneumo is bad. The tension pneumo is them dying. The tension pneumo is them dying because it's tension on the heart. Pneumo is tension on the lungs, but a tension pneumo is on the heart. It's now going to start causing cardiovascular collapse. What I mean to say is if you see JVD, it's a pretty dead giveaway that they're in obstructive shock or on their way, right? Pulmonary contusion. We know a contusion is a bruise. We may not know it a little bit too well. If you get punched in the arm, you're going to get some blood escaping the tissue. That's not great. You ever get a vaccination and then for 2 days you're like, golly, right? Imagine you got a vaccination in the lung tissue. And so now every time you take a breath, you barely move, right? A contusion on the head is not great. A contusion in the arm, maybe not the biggest of deals, but if you get a contusion of the lung tissue, that's a huge problem. So don't confuse the fact that just because it's a contusion, and we are saying this all the time, that that's not a major issue. What happens when I punch your arm? What does it look like if you've got tissue damage? A bruise, right? What is that bruise? It's blood pooling, okay? Turns out blood pooling in your lungs, not great, right? Turns out pulmonary contusion often occurs with a flail chest. Why? Say it again. Because whatever hits you hard enough to break 2 of your ribs 4 times probably squashed your lung up pretty good, right? Very good, yeah.
So you're saying that you see a contusion around the lung area?
I'm saying literally your lung tissue is contusion. You have blood and escaping and plasma having an issue there. This was us, we did this earlier on. I think we've got a decent grip of the airplane move here. What's the difference between equal and paradoxical? One means not like the other one means opposite the other, right? Be mindful of that terminology. It'll help you distinguish things for sure. Main stem intubation. Oof. What are you doing, Mr. Farron? Why are rib fractures less common in children? Say the word. Say the word. It's going to impress me. Squishy. That I'll actually do. Squishy. Huh? Rubbery? No. I thought you said peppery. Flexible? No. I'm just pretending I don't hear you. Green stick. That's why this side of the room is my favorite. I know. I just wanted more people to say it. All right, pulmonary contusion, bleeding and swelling in the alveoli. Here's what you need to know, okay? Your lungs are big sopping wet places, big moist places, right? Yeah, testify. If you get a pulmonary contusion, does that mean that the damage is causing fluid to rush to the area? Yes, that's what the contusion is, fluid rushing to the area, right? Do you remember? This goes a little way back for us. Liquids collect solids. Liquids collect solids. If you've got a pulmonary contusion, it's going to cause an inflammatory response. Your body is going to react negatively to that. Now, all you need to know really about ARDS, oh man, I'm going to skip right by that. Holy. Okay. All you need to know about ARDS is this, okay? Write this down. ARDS, acute respiratory distress syndrome, if you must, if you nasty. ARDS equals can't think of the word. I'm not just pausing for suspense. Pulmonary edema, that's what it is. I kept thinking pulmonary embolism. Okay. ARDS equals pulmonary edema, non-cardiogenic. I should have said that reversed. You said, Mr. Farron, what's ARDS? I said, well, ARDS is non-cardiogenic pulmonary edema. We already know pulmonary edema can be caused by heart failure. If your heart isn't beating very well, sorry, I had you reverse it. I was so focused on trying to think of the word, I forgot I got it reversed. Anyway, I don't know, I appreciate you writing pen, mad respect. ARDS equals non-cardiogenic pulmonary edema. Oh wait, even that's not right. No, I'm just kidding. I'm just kidding. Yeah, you'll be fine.
Perfect.
Great, good job, you're doing fine. Okay, the point is this, congestive heart failure, we'll see this pink frothy sputum, right? If your heart isn't able to squeeze like it should, blood is gonna back up into your lungs and then that foam will come out of your mouth. It's mostly plasma. Okay, heart failure causes pulmonary edema. If you hear wheezing, what do I want you to suspect? Asthma maybe, or bronchoconstriction for sure. Ours is true, but I don't want them to know that. Okay, I don't want you to know that. Right, allergic reaction. Right. If you hear stridor, what do I want you to think?
Obstruction.
It could be obstruction, and we might need epi. It could be allergic. Okay, great. Pulmonary edema, I want you to think congestive heart failure. Pulmonary edema, I want you to think heart failure. If they have heart failure that isn't because of the heart, we call it ARDS. We'll get into it, why it is called that later. So, you are in a car accident, your ribs break, and it causes a contusion of your lungs. That contusion is a bruise, meaning a bunch of fluid has rushed there. What am I concerned about? ARDS. That fluid rushing, building up in there and causing a widespread inflammatory process. All right. Costochondritis is a fancy way of saying your intercostals hurt. This is usually from people coughing too much. You ever get chest pain after like 3 days of coughing? Often that's costochondritis. It's a strain in there. Now, I bring it up here because it's oftentimes either a distractor on a test. Your guy has all these things. What do you think? People are like, well, costochondritis, that sounds super sciencey. Well, kind of. It's inflammation of the intercostals usually from pretty minor issues. Just be mindful of what that word means. The reason why essentially it mimics acute coronary syndrome is because it represents as chest pain and sometimes substernal. Oh, I forgot I made a list of things we wanted to talk about. Detailed physical. Cardiac tamponade is essentially the heart version of a pneumothorax, if you will. Right? This is not our pleural cavity, but our pericardium, this sac around the heart, filling up usually with too much fluid, and is often the result of trauma. Not exclusively, but often. Right? Cardiac trauma often result of penetrating trauma, like something poked through your chest, poked through your pericardial sac. It can be medical, like basically you have about 50 milliliters of fluid in that sac around your heart. If that fluid in there gets infected or inflamed, then it starts getting sticky and it's not going to work as it should. Does anybody know Beck's triad? Yeah? Who was that? Was that you? Man, somebody woke up for that one. Hell yeah! That's Rossi, Bex, Rodriguez. That's the... What's Beck's triad, Rossi? Uh-oh. Muffled heart tones, JVD, narrowing pulse pressure. Ayo! You'll sometimes see it as hypotension. You'll sometimes see it as hypotension, but narrowing pulse pressure is probably the best way to phrase it. Cushing's? Oh. There ain't a whole lot that muffles heart tones that isn't cardiac tamponade. I have literally never once listened to a heart in my entire career, but there's nothing that causes it isn't a muffled heart tone. JVD though, what's JVD telling me? Blood is not coming back to the thorax. What we're not sure of just yet is it not able to go back because of the heart or because of the lungs, right? But if your patient has a positive sign for JVD, it narrows down the possibility of what this thing could be to like 3 conditions, right? One of which is the cardiac tamponade. If your patient has JVD and muffled heart tones or hard to hear, then that means one thing, right? The tricky part is you got test questions coming where only 2 of the 3 triad are appearing and you have to suss out that it's that, right? Yeah. I don't remember what I was doing here. There's a 1 plus there's a 2. There you go. Good job. Make sure that you can differentiate this thing. I don't really know how to write a good Beck's triad question that's straightforward without including information from Cushing's, so there you go. They're often confused. We talked about a pulmonary contusion. That ain't great. Neither is a myocardial contusion. Why would a myocardial contusion be a problem? Same thing as the lungs, which is what? Fluid and inflammation, right? Fluid's going to rush to that injured area. Even this has a tear in it. That's not a contusion, that's a disruption. But myocardial contusion, blunt trauma, chest We got a bruised heart. That's going to decrease cardiac output. Why would we get decreased cardiac output just because we have a contusion? Because of the swelling is not allowing the heart to squeeze like it should, right? What is a dysrhythmia? Yeah, it can be irregular, but it also can be tachy or Brady, right? A heart rate that is too fast, so fast that it hurts you, a heart rate that's so slow that it hurts you, these are all dysrhythmias. Hopefully you're not surprised to hear that if I go in there and treat your heart like a little speed bag, it can leave you prone to cardiac dysrhythmias. Which is why if I go up and I say, hey buddy, again, this is the superpower of an EMT. I show up, fire's like, yeah, he's just got some chest pain. He's not sure if he wants to go to the hospital. I said, no problem. I check ABCs. He says, yeah, a little shortness of breath. I said, that's okay, buddy. We're going to figure it out, you know? I'd check his pulse and it's irregular. I said, well, do you have a history of an irregular heart rate, like AFib or anything? He says, no. I'm like, oh, okay. You now have a shortness of breath from a sudden impact to your chest with a cardiac dysrhythmia. That might be a contusion of the heart. That is a major issue. Now, he's probably not chatting with you like everything's fine like I just was, but the point is, it's just these subtle clues will help us kind of figure out how severe our condition is. Ooh, this one's fun. Commotio cordis, not just your next Harry Potter spell. Commotio cordis, commotio cordis. Pew, pew. Commotio cordis is basically what happens when the electrical activity of your heart gets disrupted at the exact wrong moment.
Yes, what was his name? Yes.
The football guy?
Yes.
Ain't it always? Yeah.
On the field.
Yeah, that's what, you know, anytime it's like, yeah, so this young guy that didn't do any drugs was playing a sport. I'm like, Commotio cordis, that's my guess. The idea is essentially is that here's a cardiac heart rate, a heart rate being displayed on a cardiac monitor. This is depolarization of your atria. This is depolarization of your ventricles, right? Just at the time, you ever flush a toilet, but really it was kind of a two-flusher. Now you got to wait in your own filth, waiting for that sucker to fill up, just bearing all the sin of the world, right? Okay, this period right here in red is that toilet bowl not, or that the back of that toilet not filled yet. Your heart needs to depolarize and then it needs to recharge before it discharges again. And if I hook a car battery to the wrong moment, I'm going to cause you to break that toilet handle off. Or to get out of the metaphor, essentially, if the heart can generate electricity on its own, so too can electricity be generated if we cause an impact. As medics, we were taught to do precordial thumps. You know how we defibrillate ventricular fibrillation? We used to be taught that if I think you're in VFib, I just hit you on the chest as hard as I can to generate a small amount of electrical activity with the hopes of resetting your heart. That's what this is doing at the exact wrong moment. It is causing electrical activity at the time it is most vulnerable and needs to recharge instead, and it will put it into VFib. Now, I should mention, it'll look like a seizure. People, when they go into VFib, if your heart is having a seizure, you might look like you're having a seizure as well. It causes you to shake. And if you show up on these calls, sometimes people will tell you, oh, he had a seizure. He just started shaking and he fell down. Right? So we need to be mindful of chest trauma with commotio cordis. Myocardial rupture. I'm not going to spend a lot of time here. We talked about a contusion. A rupture is a tear, right? You know what a good sign and symptom of myocardial rupture is? Cardiac arrest. I've never shown up and been I've never transported a patient that was actively experiencing myocardial rupture to my knowledge. Why? Because they're dead when I get there. If you have a tear in your heart, you die fast, real fast. Oh, we're gonna do it. We're gonna get there. I have 10 minutes. This is great. I'm so proud of us. Okay. This is a major source of confusion. Aortic dissection, aneurysm, rupture. Major source. An aneurysm is a balloon. You see my cute little balloon? An aneurysm is a balloon. Now, before this class, you might have heard, oh, my grandpa's got an aneurysm. And you're like, oh, is that like a bleed in the brain? No, it's not a bleed in the brain. An aneurysm is a balloon. Basically what happens, you can get it in your brain, you can really get it anywhere. But if we're talking about the aorta, which of course comes off the heart and goes all the way down to your abdomen, so you have a thoracic aorta and an abdominal aorta, it's a vessel with muscle lining it. And what will happen over time, usually due to atherosclerosis or plaque on the vessel walls or high blood pressure, is it will essentially, if your blood pressure is always 160/90, there's too much pressure blowing up your balloon. And over time, it will thin the walls in places, and it will bleb out like this. It will bow out. So usually it's the cause of chronic hypertension. The risk of it is that if it was a thinning wall in the first place that causes it to balloon out, the next time you have a major trauma in that area, it is way more prone to rupture. Okay? So that's an aneurysm. An aneurysm is the balloon. You might have chest pain. Why would you have back pain?
Spinal back pain?
He's like, oh man, I feel like I can't breathe. And God, I just had this sharp pain right in the middle of my back.
No.
It's not the spinal. Why would an aneurysm present with back pain? Put pretty simply, because that aorta is deep in there, right? If I hurt just at the tip of my left nipple, I could pretty much pinpoint right where that issue was. Back pain would be weird for that, right? Be like, no, you put the Paisley on wrong or whatever that thing's called. Okay, but if I've got back pain, that aorta is in there. It might represent as back pain because it's behind the issue, right?
That balloon is caused by blood or air?
So it's kind of neither. It's like if I've got an artery in my arm and I just keep my blood pressure at 200/100 all the time, all of the veins and arteries in my body are overexpanding too often. And in some of those places, they will thin. And so now when pressure happens, they will balloon out in those areas. So blood, I guess, is the answer. Mm-hmm. Say it again. Yeah, but I don't really want to talk to him. Now, in an abdomen, because that's where our aorta goes, I mean, you can feel, on a thin enough person, you can feel their aorta if you press hard enough. Okay. Now, pulsatile mass would be an aneurysm in the abdomen that you can feel. Listen to me when I say, if you suspect a pulsatile mass, don't go jabbing around for it. You're going to put your finger through it. But it is a pertinent negative for an abdominal assessment to say, hey, I lightly palpated the abdomen. I noted no pulsatile mass. What was your question, Rossi?
Like, there's some kids in their stomach hurts, they're like, do we just assume, you want us to assume the worst and assume it's like an abdominal aortic aneurysm?
I don't think I don't think you'd get the test question right if you assumed a child had an abdominal aneurysm, but I do think that it would probably be good clinical care to tell the parent, like, look, I don't know why your son hurts. Maybe it's the things he ate, but maybe it isn't. There's all kinds of other conditions that could cause it. I think we should go to the hospital and get it scanned. Let's be delighted to find out it was just too much sugar, right? Now, aneurysms are often caused due to profound pathology or chronic hypertension, so I'm not thinking a kid has an aortic aneurysm, but he might have been born with it. We don't know. Gage? Yeah. Yep, that is a stroke. A ruptured aneurysm in the brain is a stroke. The aneurysm isn't a stroke, but the rupture is. The aneurysm leaves you prone to the hemorrhage. Not only that, but an aneurysm leaves you prone to dissection. Think about it like this. You remember Mallory Weiss being a dissection largely of the esophagus?
Yeah.
An aortic dissection is like a Mallory Weiss tear of the aorta. Borhave's is the rupture. Now, because this is a shearing force, this is the lining, picture there's a couple of layers here, tunica media, intima, these kind of things, but let's say there's a couple of layers of tissue here. If you get blood in between those tissues because they tore, we call that a dissection. Okay? Now you can die from a dissection because they can rupture. An aneurysm doesn't kill you, a dissection may not, but either of those things will lead to rupture, and that is a huge problem. The rupture is going to kill you fast, and I shouldn't say you can't die from a dissection. You can, but the rupture is what will kill you fast. Now, an aneurysm just feels like pain, but dissection and rupture feel like tearing pain. If your patient complains of a tearing pain, there are basically only two things it's going to be. And if they don't have a womb, then it's an aortic dissection or rupture. It feels like tearing because it is tearing. And so it is very, very important to ask your patient, how does this pain feel? Man, like a knife being dragged through me. I'm like, that sounds horrible. Would you describe it like a tear? Yes. One hospital, please. Gage? I don't think so. I think as if it doesn't hemorrhage out and kill you, then it just is self-contained and doesn't go intravascular. Tearing or burning. Another dead giveaway, a blood pressure difference between arms. Your aorta, right? This is a crummy version of a heart right here, but your aorta, well, actually it's just the aorta. I guess the heart would be down here. Your aorta comes off in an arch, right? The aortic arch. And those up here are going to your left arm, right arm, and your head. If you have a dissection before the blood gets to your left arm, it's going to change your blood pressure. So will you often see a difference in blood pressure with a dissection? Not necessarily, but if it dissects between where it's going to your other arm, then it can change that. So if I got a guy essentially who's got a sudden chest pain, right? History of hypertension, I might think heart attack, but it could also be an aortic dissection. So you might see a test question that says something like, you've got a 50-year-old male with a history of chronic hypertension, complains of 10 out of 10 substernal chest pain. You note a blood pressure of 130/80 in one arm and a blood pressure of 110/60 in the other arm. What should you suspect? It ain't heart attack. You should think dissection. Specifically a thoracic dissection, because that's the only one that's going to change his blood pressure. T? No, as long as you know that the blood pressure change only happens with the ascending. This is why it changes your blood pressure. You can see here in the aneurysm, our inside diameter is actually larger. An aneurysm is going to allow more blood to flow through, if anything. But a dissection is causing a ballooning into the vessel. That's what's going to change the blood pressure in the arm if it's happening there. Now, you don't have to remember all of that so long as you know that the blood pressure arm to arm is dissection, not aneurysm. We got 3 or 4 questions that are all just, which type of aortic what's it do you think this is? Dissection, aneurysm, rupture, so forth. So there's a comparison chart in your book talking about how to differentiate the two. I don't stand by this list. I think it's lunacy to be able to draw a tight line in this and be like, well, actually, this is acute myocardial infarction based on these specific details. I'm like, okay, careful with that. You don't know that. I mean, there's some obvious things in here, like the blood pressure discrepancy. Okay, yeah, heart attack's not going to do that, right? But like tightness, pressure, sharp, tearing, sure, gradual, abrupt. Oh man, I've seen a million heart attacks appear a million different ways. So I'd be a little careful with things like this. This, however, is a good list. And honestly, if I were studying for my own tests, most of my studying would just be charts like this. We've got our condition on the left, and then we have all of the things that it could be on the right, and I would be circling the ones that can only be one thing, right? Like we got a chest trauma coming up on this test. If you have flat neck veins, it ain't this, it ain't that, and it ain't this. Flat neck veins means basically only one thing, low volume, right? If it's distended neck veins, well, thankfully that takes me out of the wheelhouse of about a million things, but it narrows it down to 2 or 3. So finding out what these distinguishing signs and symptoms are is how you're going to be able to kind of solve the grand mystery.